Hearing will come back to order. Remind the witnesses they're under oath. When we left off, I think Chairman Waxman had finished, so it would be to Mr. Gingrey for questions, please.
Mr. Chairman, thank you. I'm going to start by asking a few questions of Dr. Evans. Dr. Evans, in your testimony, you state how important it is that the information patients receive be of high quality. From what you've seen and heard today, from the previous panel and from your co-witnesses on this panel, do you have confidence that patients are indeed receiving high-quality information from these companies?
I think there's two parts to that answer. With regard to what physicians call analytic validity, that is, if they tell you that you have an A, one of the DNA building blocks, at this position, I believe it. Okay, absolutely, they do quality work from an analytic standpoint. However, with regard to quality related to what we call clinical validity, that is, what does this tell you about your risk of this disease? I would say absolutely not. And the GAO experiment shows that in a beautiful way. No one knows how to interpret these data, and that's quite clear. So the quality information, to be of quality, must be meaningful. It is not meaningful, and therefore I would say no, this isn't quality information.
So measuring one's blood pressure and finding that it's elevated, or measuring one's cholesterol and finding that it is elevated, or measuring one's blood sugar and finding that it's elevated. Mm-hmm. These are not comparable then to this information that you would get in regard to this genetic testing.
That's absolutely correct, because there are two reasons. One is that I can go to 3 different doctors, and if these doctors are doing their job right, my blood pressure is gonna be reflected the same at each place. My cholesterol should be essentially the same, give or take some degree of variation. But as we've seen here, you send the same
from the slide that Chairman Stupak presented in the first panel.
Not comparable
GAO.
information.
Yeah. Well, it reminds me of, and thank you for that response. There are scans that companies do to detect the amount of calcium in one's blood vessels, whether it's the aorta or the coronary arteries, whatever. I mean, you just get a report back and it's if it's a lot, I guess you'd say it's 3+. And I have a brother that's a year and a half older than me. He doesn't like to admit that, but he had one of these tests done, and it said, oh, yeah, you got a lot of calcium, and you better go see your cardiologist. Well, it took him 2 months to get an appointment. It's a wonder he didn't have a heart attack in that time from anxiety, but he ended up seeing, but finally he ended up on the operating table for a coronary angiogram, which showed that he didn't have as much as 60% blockage in any vessel, and it was just a curiosity, really. Right. And he ended up probably spending about $10,000 in the process. And of course, the coronary angiogram is not without risk. He could have had a heart attack on the table.
That's right.
So I mean, this is the kind of thing that, as a former physician, well, I'm still a physician. I've got an active license.
Once
thank
a
goodness.
physician.
But I'm concerned. I am concerned about it.
Yeah, Dr. Gingrey, your comparison is absolutely apt. The advent of this type of testing is, I think, entirely comparable to these scans, which we simply don't know how to interpret, and which, when misinterpreted and not understood in context, can lead to harm.
Well, you even in your testimony, Dr. Evans, suggested that it's kind of an entertainment thing. It's sort of like Dr. Burgess earlier in his questioning was talking about these ultrasounds that are done in the shopping malls, and they're they're more than 3D. They're 4D. Right. And they're for entertainment purposes.
Sure.
I want to switch quickly in my remaining time, Mr. Chairman, to ask maybe the triumvirate of Ms. Gould and Dr. Varner, Dr. Becker. Do you agree that what you're providing to these patients, if you will, or direct-to-the-consumer information about their genome is more for entertainment than it is for a real therapeutic, possibly, and diagnostic value?
Dr. Ginger, I'd like to respond to that. First, I appreciate and think it's very important that Dr. Evans is on this panel, but I want to make it clear that there is no uniformity in the academic medical world around issues like this. There is indeed, for instance, research that shows that behavior does change. Second, I think your analogies to high cholesterol and hypertension are apt because the genetic risk information that is imparted is relatively of the same predictive value of hypertension and high cholesterol. And just as we know many people who may drop dead at the age of 90 despite having high blood pressure, and we know people that have many risk factors and continue to live on and on, these are probabilistic. They are not predeterministic. And so the information that genetics is uncovering is analogous to the risk factors that you used in your practice and I use in my practice today. There are often analogies made to the body scan industry, for instance, and we don't believe they're apt as long as you have a healthcare professional to support and interpret the information. Most of the body scan industry came out of the fact that you had vulnerable consumers that were getting these CAT scans and then the information was handed over to the physicians and they didn't know what to do with them. There's clearly an educational gap in the physician base. More physicians need to be educated about genetics, but the ones that are, for instance, we work with a couple hundred physicians, very much know what to do with the information because it's akin to the risk information they've been using for all of their practice.
Dr. Vania, I'm going to have to let your response suffice for the other two because I'm 2 minutes over or a minute and a half, and I'll yield back.
Thank you, Mr. Kingrave. I know there's more questions. I know Mr. Burgess has some. Let's go another round here. Dr. Evans, could you grab that book right there? I got a couple questions I want to ask you. Someone hand it to him. Thank you. We've talked a lot about direct-to-consumer testing. Companies offer a variety of products for their clients. One type of test looks at how a person reacts to and breaks down certain prescription medications. This is obviously can be very useful when a person is diagnosed with an illness and the physician is developing a treatment plan. But I want to ask you, take a look at exhibit number 6 there. But when it's done with direct-to-consumer testing, in that world, it really raises some questions. Because if you look at exhibit number 6, this is an internal Navigenics document that shows a consumer's test result for the processing the drug. I need your help there.
Irinotecan.
Okay, irinotecan. That drug is commonly used for treating colorectal and other cancers. The document shows us that this consumer has a low risk of the side effects for this drug. The document then goes on to say that if he or she is being treated for cancer, then their medical team may want to prescribe irinotecan. Dr. Evans, in your opinion as physician, do you think this document provides medical advice?
Well, clearly, yes. It's providing advice.
Okay. Dr. Vanessa, this is your company, right?
Correct.
So are you giving medical advice for this patient here?
In fact, the statement you read suggests that the patient should do anything in consultation with their physician. In no case do we recommend that anyone take independent action. This is specifically why we have genetic counseling support and why we primarily work through physicians.
Right, but isn't your document, if you take a look at it, if you want to see it, it says your patient's risk of side effects, you have a high risk here, it says. Let me make sure I'm on the right one here, number 6. Okay, this is a drug. Your side effect is low risk. And so are you not given medical advice? I mean, where does it say there, consult your physician?
So the statement, Chairman Stupak, if I understand what you're reading, is based on your genetic markers, you're likely to have low risk of side effects.
Right. So based upon you're likely, these can have, okay, go ahead.
So those sorts of statements are pulled directly from the pharmacogenomic literature. And in fact, the pharmacogenomic markers on our panel, in many or most cases, come from the FDA list of qualified markers.
Sure, and then it says, right underneath that where you read, it says, we determine your risk by analyzing your genetic code. So by looking at the little vial of spit that they gave you, you made the determination that this individual should take this drug for cancer, right? It would be good for them if they had cancer, right? They should take that?
We specifically point out that it would be helpful for the medical team to know that they're at low risk. And in fact, irinotecan testing, along with, for instance, Plavix testing, is an area of great interest for oncologists and cardiologists today because the data is robust.
So, Okay, well, let's go to the next one. Let's go to exhibit number 5 in that book there, okay? The document is given to physicians whose patients recently had genetic testing done by, again, your company. The document notifies the physician that his or her patient is likely to have a high-risk side effects of the drug Abacavar, how to say it? Abacavar? Abacavir, a drug commonly used for treating HIV infection. The document goes on to inform physician they may want to tailor the patient's therapy to reduce the chance of Abacar hypersensitivity and list 4 treatment options. Again, isn't this given medical advice?
No, the bright line that's often drawn here is we do not specifically state, because the data does not support it, which drug the physician should use, which dosing that they should consider, et cetera.
Well, then why do you bring up this drug then, if you're not telling the doctor which drug to use?
It's information that simply should be taken into account. For instance, the FDA simply recently put a black label warning on Plavix, that there are different genetic responders. In no case, for instance, for Plavix, do we tell the physicians what to do. It's simply raising an awareness in just the way the FDA did with their labeling.
And Dr. Evans, do you think they're giving any medical treatment here?
Well, it certainly seems to me to be medical advice. And I think that this is an example, these 2 examples are very good exemplars of the fact that some of the information contained in these scans has robust genetic and medical implications. Therefore, this is, I think by any common sense interpretation, medical advice.
Dr. Vinay, do you certify all these letters that go out as the doctor then for Navigenics?
Yes, we have a medical advisory board that looks them over.
Okay, do you though? Do you personally?
Yes.
Okay. So, if, as exhibit number 5 or number 6 there, Dr. Evans, if I came to you as a patient and gave you this, what could you take from this information that I brought to you as I received this letter from Navigenics?
Right. I would probably do 2 things. One is, especially in the case of Abacavir, the data are so robust that show that if one has a particular version of this HLA gene, that they're much more likely to have a serious reaction to Abacavir. I would take that very seriously. I would be very tempted to repeat the test because of all of the tests that have been done at the same time, but I have no great quibble with the analytical validity. I trust that result. My quibble with that particular issue is that it's medical advice.
My time's expired. Mr. Burgess for questions.
Thank you, Dr. Evans. In your written testimony, and I think you addressed it in response to a question, the issue of being at increased and decreased risk, and if someone's at increased risk, there's someone out there at decreased risk, and the advice might be inappropriate in both instances. Now, there was quite a flap created in this committee a little less than a year ago when the United States Preventive Health Task Force came and with some revised recommendations on mammography, and individuals between 40 and 50 no longer need them. Well, it turns out they walked back from that, and there was also some concern that the health bill, as it was being written, would incorporate some of those things such that people covered under specific plans might end up not being covered if those guidelines fell outside the U.S. Preventive Health Task Force. Would it not be worthwhile if that world was the one that had persisted and existed today when the bill was signed into law? Might this type of testing not be helpful for a woman between 40 and 50 to assess whether she go out and purchase on her own the screening test that might be life-saving?
Actually, no, for a couple of reasons, Congressman. Number one, the degree of risk determination that these types of tests generally provide is so lacking in robustness that we really don't know whether a woman should be getting mammograms early or not based on these kinds of results. It's very different from the situation for, say, BRCA1 or 2, the genes that, as you know, confer an exceedingly high risk of breast cancer, in which we've got pretty good data to suggest that those women need to be treated very, very differently. These results, however, aren't of sufficient robustness to really guide who in the population should get mammograms early or not. And I would also, again, go back to the GAO experiment, which shows that we don't know how to interpret them. In other words, we will be misassigning women right and left if we try that to high risk or low risk. That's...
Well, but the U.S. Preventive Task Force may have just misassigned everyone in that age block.
Unfortunately, the reality is that in medicine, we although from a wishful thinking standpoint, we might want to be able to assign people a very precise risk. The reality is that we are not good at it, as the GAO report shows, and that we're asking for trouble, in my opinion, if we start telling a woman, you don't need mammograms until X date because of your genetic profile.
Well, but that's not the issue. And I would just submit, and I've got some of the same concerns that everyone else up here on the dais has, but I would just submit that in a world that at one point seemed to be rapidly moving to one-size-fits-all government-controlled medicine, I would think the consumer could see real value in being able to assess whether they individually might need to make a different decision than their government would make, in which case this type of testing, I think, could be extremely effective. Now, Okay, go ahead.
If this type of testing were consistently, if we're consistent between labs,
right, and we have a federal agency who is responsible for that, and my hope is that they will now respond and provide the background and the guidance that the consumer needs, not so much the provider needs. Let me just ask Ms. Gold a question before my time runs out. Now, you referenced in your written testimony an individual who had an increased likelihood of a deep vein thrombosis, a blood clot, an increased propensity for blood clots, and wasn't aware of this until the testing was done. I mean, I'll just tell you, as a practicing OB-GYN, I mean, nothing strikes more fear in your heart that you might do a relatively minor procedure on a very young and healthy person and have them spend weeks in the hospital recovering from a deep vein thrombosis, or worse yet, die of a pulmonary embolus. I mean, that is one of the most frightening things that we can face in medicine. You can imagine from a medical legal standpoint, it's extremely concerning. I was intrigued by that story that you included there. We went from a world where early in my career, you just accepted that as a risk, to later on, everyone got a low dose of heparin right before surgery because we lived in a medical legal environment that you just couldn't tolerate the 1 in 10,000 who would have that complication. So what has the experience been at 23andMe? Are you guys following this? I mean, that's a compelling story, but an anecdote doesn't a series make, so you need at least 2 anecdotes to make a series. Have you been following that?
Yes, and we do have several customer stories, and I think this goes to, there was the word used, fantasy, before. We strongly disagree with that. Colleen McBride at NIH has written that when people get access to their online genetics, it can be very empowering, and it can be a great opportunity for a physician to leverage that to help them make better lifestyle choices. We've had a number of examples where people getting access to this information that they would otherwise really not have known, and talk to their physicians and healthcare providers, and have seen better health outcomes.
Well, I'll just say it from a clinician standpoint. I mean, you welcome all information that comes from any source, especially if it's going to keep you out of that kind of trouble. Thank you, Mr. Chairman.
Thank you, Mr. Burgess. Ms. DeGette for questions.
Thank you, Mr. Chairman. Thank you for your commentary. Ms. Christensen and I had to run over and vote in the Resources Committee. I have a couple of follow-up questions that I wanted to ask. The first one is on the privacy issues. And as you know, we only have 5 minutes, so if people can be relatively short in their answers, I would appreciate it. Ms. Gould, does your company believe that we should protect the privacy of medical information of the people who undergo this testing?
Yes, we absolutely
Thank you. Dr. Vignier, you need to answer verbally.
Yes.
For that. And Dr. Becker, do you believe that as well?
We absolutely believe in that.
Okay. Now, for Dr. Vignier and Dr. Becker, I realize you did not see the GAO report until this morning, but in the previous panel, Mr. Coots testified that the 2 companies that told the young woman online that her fiance could send in their medical information to surprise him with his genetic background were your two companies. And I would assume from both of you that you have specific policies against this practice, correct, Dr. Vanier?
If you will, Congresswoman.
Well, I asked Dr. Vanier, and then I'll ask you. Does your company have a specific policy against this practice?
We do, and I
Thank
would also
you.
like to correct the assertion that that was our company because it was involved in ancestry, and we do not
Okay.
offer it.
Well, no, I wasn't referring to that specific audio clip. He said, and again, this is a little unfair to you, I realize, because you haven't seen the GAO report, but he said the two companies that told them that they could send in their confident or the fiance's information were your two companies. So, but if that was the case, that would be against your company policy, correct?
Correct. I would
Yes.
strongly like that information.
Yes, I bet you would, and we'll make sure you get it. Dr. Becker?
That is correct. It's against our policies. We take responsibility for that particular action and feel that action was reported. I'm aware of that. That was
Okay.
reported very quickly after that discussion with customer service person
Okay.
happened.
So
we
that
took
was your
appropriate
that
training
clip was from your company, and that
That
is
was.
against your policy, right?
That is against our policy.
So this leads to another question, because all three of the companies represented here are companies that are trying to do important work, and I don't think anybody well, maybe somebody on this panel, certainly not me, would object to this type of information being gathered and given to consumers. What we're all concerned about is the same thing you're concerned about, is that it be done to a high degree of medical certainty, and that people and that their privacy is ensured, and also that they get adequate medical advice. I think we can all agree with that. And so my question would be to all three of you: how do you think that we could protect confidential patient information if you have essentially telemarketing individuals on the phones talking to folks about these tests?
If I will,
Sure.
Congresswoman, thank you very much for the question. We did take action to train that person and correct the ability of that to happen. So this was a customer service agent. We take it very seriously, this particular incident, and we have we no longer will do that.
Okay, well, that's good. Dr. Vanier, do you have anything to add to that?
I do. I think we can look at the Genetic Information Non-Discrimination Act as a first step of an important series of legislation that would include genetic protections for consumers. And
But that's already in effect, that act. And
But it speaks to the fact that obviously individuals, that health plans and companies should not have access to that individual genetic data. I think that's a model of how you can begin to understand other legislation that would protect individuals.
So you
genetic
think
data
we
at a
might
corporate
need
level.
additional legislation because of the narrowness of that act? Is that what you're
Yes.
saying? Okay. Ms. Gould, what would your view be on that?
Well, we have strong both policy and technical safeguards to protect customer information, and we agree that privacy is of utmost concern. We think GINA is a great start, and agree that likely more will be needed in the future.
Thank you. Mr. Stupek, I think everyone else has had 2 rounds, but Dr. Christensen. So should we have her question, and
Correct.
then I'll take my second round?
Sure.
Thank you.
Ms. Christensen for questions.
Thank you both. My question, I guess, would first go to Dr. Becker, and if you could turn to Exhibit 11 in the binder. Mr. Kurtz testified earlier that none of the companies was able to provide a complete genetic analysis for the DNA samples they submitted with African American and Asian profiles, and this is apparently due to limitations in the ethnic composition of the studies that the companies use to predict their customers' genetic risk. Exhibit 11, at the bottom of the page, is an internal email dated November 12, 2009, that Pathway produced to the committee. In this document, one Pathway employee has sent another a proposed script for handling customers who self-identify as African American or Hispanic, and thus will receive a more limited genetic analysis. According to Pathways document, the company first notifies customers of the limited available data when their report is almost ready to be sent. And the script for those of African descent indicates that they'll only be able to provide limited information. For example, for females, just 3 conditions: Alzheimer's, lupus, and type 2 diabetes, and for males, 4: Alzheimer's, lupus, type 2 diabetes, and prostate cancer. The script makes clear that the customer had already self-identified as African American. So why doesn't Pathway tell African American customers that the company would not be able to provide the full data before they make their payment, and before you, not just when you're ready to send the results?
Actually, Congresswoman, we do now do that activity. As you described, we do inform on our website. There's a clear matrix of what conditions you will get depending on what reported ethnicity.
So you now inform the clients and the customers before they make a payment?
Yes, we do. And if they
limitations
came
are?
on to our customer site without reviewing that information, it is our and clicked on and paid, and then were disappointed with what they got, it is our policy to actually refund their money and discuss any questions or concerns they may have.
Okay. Well, in the case of the Hispanic, I think it was a Hispanic, yeah, the self-identified Hispanic customers, the proposed letter recommends that we set, quote, we set your ethnicity to Caucasian. Are the results accurate if you change someone's ethnicity and compare them to data for the wrong population?
The results that we present are based on the ethnicities and the findings in the literature for those ethnicities. So they are accurate for those ethnicities. And we are informing Hispanics to look at that information in that context, that this is information based on Caucasians.
And you feel that it provides accurate enough information despite the fact that they're based on people of European descent rather than?
Well, that's a very interesting question that comes down to the actual population mixture of the Hispanics. And the current literature suggests that Hispanics are actually divided into groups that are derived from Africans and Caucasians.
Well, you already don't have much in the way of African information. But, Ms. Gould, 23andMe produced a committee an internal email also dated June 23rd, 2008, concerning a complaint that an Asian American customer who was unhappy that her genetic report was based on data from a European population. It's exhibit number 3, I think, in the binder. Are the results your company provided to this Asian American customer as accurate as they would have been if you had data from an Asian population?
So we provide context in our reports where the underlying study, the populations in which the underlying studies were conducted, and we make that clear in our website as well, that we can only provide data, and we provide this in the claim process before people get their data, that genetic research is not comprehensive, and one of our core missions is actually to undertake more research. In fact, one of the projects that we're hoping to start is to try to replicate or fail to replicate existing studies in African American populations. We do think that it's critical that more research be done in order to show the applicability of the existing research in various populations. Unfortunately, most of this research, which has been NIH funded, has primarily been done in European populations. This is one of our core missions, is to make this.
We're very concerned about including more racial and ethnic minority populations in clinical trials and studies as well. But it seems, unless something has changed since we have this data, you were not apparently telling individuals that their data would have been limited if they were Asian or if
We do provide that, and we have provided that information previously.
my time is up. I'll come back.
Thank you. Mr. Gitt, you had some follow-up
Thank
questions?
you. I just have a couple of follow-up questions. Dr. Becker, you had testified in your statement that you felt that FDA approval of these tests as medical devices could stifle innovation. The chairman talked a little bit to Ms. Gould about the idea of FDA approval as medical devices, and I'm wondering if you can briefly tell me why you think that would be the case.
Well, I don't believe that it's FDA approval per se, but the current structure of requiring pre-market approval could actually inhibit the ability of this information to be accessible to people.
And why would that be, sir?
Well, because some of this, if pre-MA approval is required for all of these tests, it will take quite some time to collect potentially the clinical validity as defined today.
So is there some alternate mechanism at the FDA that you believe could serve all the purposes we're talking about, to give a consistent level of data to protect patient privacy and also to regulate the kind of information they're given? Is there some alternate process at the FDA?
Well, we do, and we do support Dr. Shuren's proposal this morning, but we also...
And I'm sorry, which proposal was that?
He proposed a way forward, and I don't remember all the details exactly of that, but he proposed a way forward that sounded very fair and reasonable, which I think is definitely the FDA's goal here. I don't want to speak for FDA, but well, I'm sorry, I'll stop.
Dr. Vanier, I wonder if you can comment whether you think that FDA approval as medical devices is the appropriate route to go.
I think history shows over and over again that the correct, deft regulatory touch both protects the public and leaves the door open for innovation. Dr. Shuren's proposal that it's the genetic markers that we use in our tests that need to be standardized and regulated is something that we would certainly support.
Okay, yeah, and that's great, and I support that too. The concern that I have, and I think probably many members of this committee would share that concern, that's only one component of what the problems that we have are. So how would we address those other problems in an alternate way?
I think another component of the regulatory process that has been discussed before is the actual collection kit, the kit in which you, for instance, submit your saliva.
Right.
There's a history of that potentially needing to be a Class 1 device, and I think that's also an appropriate area to be looked at.
Okay, what about the privacy? Well, you already talked about that other issue. Dr. Evans, I'm wondering if you can comment on all of this.
You bet. I think it is absolutely critical to apply a deft hand to regulation. Too blunt of regulation could stifle the ability of companies and academic laboratories to develop tests. So it is important. I think the two things that I find most heartening by the FDA's approach are to take a risk-calibrated approach to testing. That is, you subject tests that have higher stakes, right, to more regulation. And secondly, as was pointed out in the first panel, that one may be able to envision regulatory schemes which look at a subset of markers or a given platform and not have to clear every single test, so to speak.
Mr. Chairman, I want to say two things. I think I can probably speak for all of us that we're pleased that this panel has recognized that there's a need for improvement in standardization in the industry. And I would also, it's always the practice of this committee to allow panel members to offer questions and in writing. I think that's particularly important in this case because all of us just received the GAO report this morning. So I'd ask unanimous consent that we would all have additional days to submit questions in writing to this panel, but also that they would be able to supplement their answers in today's hearing based on the GAO report that they've been given.
As the gentlelady knows, we always have 10 days to put it forth additional questions. So, would you yield on that point?
I'd be happy to.
Let me ask our panel this then. In light of what Ms. DeGette said and what we've seen, our hearing has shown that there is a gap between claims made by genetic testing companies and the value of the information actually given to the consumer. And as Dr. Evans says, it's more entertainment than medicine. So let me ask you this then. Would you agree that until the FDA develops standards for testing, uniform standards for how you're going to test, uniform standards for genetic markers, and assure the accuracy of the tests, and standards for interpreting the test results, would you agree to stop this direct-to-consumer marketing for monetary value until the FDA has this standard set? Ms. Gould?
We don't think that that's the answer. We, again, believe in the accuracy of our tests. We provide
So you're still going to
clear
continue marketing
transparency.
this
We
test
think that it's appropriate that we continue and that people have the right to access their genetic information.
for entertainment or for medical reasons?
So we provide our information for informational and educational use.
Okay. Dr. Venet would.
Chairman Stubeck, I think it's a great question, but one put in the context of where we are as an industry. We're at the dawn of an era of personalized medicine, as the committee has pointed out, and as much early interest as there's been in the American public, I think it's important to understand we are all small businesses. I suspect no one on this table flew in on a corporate jet this morning, for instance, and so stopping any sort of offering in the public, typically from a venture capital perspective, means that most of the product category goes away for many years.
Well,
in our case specifically, because we distribute mostly through physicians and prevention and wellness programs, we would like to continue to be able to do so given the healthcare support that we give.
Okay, so let me frame it like this. How much do you charge for one of your tests?
Right now we're at several $100s.
Okay, several hundred. How many of those 700 is for profit?
The gross margins range to actually, I'd put it this way. We are a pre-profitable company. We're still venture capital funded. We're losing money every year.
Okay. So would you stop marketing for a profit then? Would you stop marketing tests for profit? I know they claim they don't make a profit, but how much money do you draw off every year for this testing of Navigenics? Because that's part of the company's cost, right?
Understood.
So, I mean, if you're doing this for public good, why would you charge people then? So we can build these databases and do genetic testing. But even if we did that, we need uniform standards, don't we?
I understand. I think most of the innovation in healthcare business shows that you can do well by doing good, and I think hopefully that's what we're continuing to would like to do.
We haven't seen anything good yet. How about you, Dr. Becker? Would you stop marketing then until we get some uniform standards and testing here, and so we can interpret these results? I mean, American people are spending $1 billion a year for nothing.
We think developing standards is absolutely critical, and being involved in that process should require the members at this table. And in order to do that, we should have the ability to have jobs.
Sure.
And continue to work hard and help FDA and Congress and
so would you stop marketing while we're helping FDA and Congress set
we would
standards?
prefer not to stop marketing as we are today, and we are working similar as Navigenics with physicians and wellness programs. And so we have physicians involved, we have genetic counselors involved. We feel that it's important to allow the public access to this information if they want it, and present it in a responsible fashion, telling genetics what genetics can and can't do. I think it's very important.
So would you pay a physician to be involved in this? Would your company pay a physician to be involved in this?
Yes, we would.
How much do you pay them?
That is not my area, and I can get back to the
okay, we'll follow it up
committee.
in writing.
Yes.
Okay.
With that?
Burgess?
Let me ask you a question. Are all three of the companies represented here today based in the United States?
Yes.
Yes.
Yes, we are.
Now, one of the companies that's not here, Decode, is based in Iceland. Are any of you currently marketing your products in Europe, for example, in the European Union?
We do offer our services in Europe.
We're mostly in Asia and Canada.
We currently do not offer our products.
What is the experience with offering in Europe? What is the regulatory environment in Europe as relates to these products?
We haven't heard any specific issues around this.
Europe has a similar regulatory agency to the Food and Drug
They do.
Administration. There are obviously some differences, but so far they've not shown any interest or curiosity in what's going on.
Correct. To my
And
knowledge.
and the Canadian equivalent of the FDA, Dr. Vanier?
Currently, no.
So at this point, the only regulatory efforts that you're aware of are coming from the United States?
No, let me recharacterize my
Okay.
statements. While we have little commercial experience, for instance, in Europe, clearly genetic testing is an area of regulation in many countries. I know England has been taking a look at it. Germany has been taking a look at it as well. So I think, and there are clearly many personalized medicine coalitions and efforts in Canada as well.
And can the experiences of those bodies inform the activities that we're going to embark upon at the FDA? Is there a possibility for sharing learned experiences?
I think that's always the case. However, in this specific case, I believe the FDA is showing leadership compared to their counterparts abroad.
Well, let me just say that personalized medicine is. I do believe that's the wave of the future. In fact, that's one of the things that concern me so much about this bill that we passed and got signed into law 3 months ago. Was it moved us away from an environment of personalized medicine and moved us more into a regimented command and control type structure. So I for one am encouraged by what you're doing. I do want it done right. I do want the consumer protected, and I do want the information to be believable. Yes, the FDA has a role to play, but I would submit that each of you and your companies has a role to play as well. And yes, while there's some proprietary and some competitive issues to be protected, there is also the greater concept to be protected as well, which is allowing consumers to access information just as we would a blood pressure or a cholesterol or a blood glucose at a health fair that might be done at any one of our churches or community centers back home. So I think, Mr. Chairman, that's probably the extent of what I had. I did want to see if we could perhaps recall.
Mr. Burgess, we'll do that. I owe
okay.
Ms. Christensen another round of questions if she'd like, and I'll wrap it up with this panel, and then we're going to back Mr. Kuntz. He's still here. I'm going to recall him.
Am I next?
Yes, Ms. Christensen, questions?
Yeah, thanks. Just to continue the same line of questioning I had before, do all of the companies represented here have disclaimers regarding the limited results that would be available to people of different races and ethnicities?
If I actually may correct an assertion made by Dr. Coutts, we do not collect any sort of ethnic information from our patients whatsoever. But we do certainly as well help educate them about the promises and limitations of the information given the state of the ethnic literature.
And that's prominently displayed somewhere on your website?
Yes.
The answer is yes to the other two. So what if someone doesn't, happens to miss that? I'm hoping that it's really prominently placed on your website. Don't you think that someone should follow up for those? I guess I would be asking Ms. Gould and Dr. Becker, since you two do ask that question. Follow up to find out if a person says they're Hispanic, Asian, or African American, or Native American, and do you feel an obligation to go back and check and make sure that they understand that the information is going to be limited, or don't you think there should be a check mark or something to make sure that they see that they've seen that and noted that before they send in their payment?
I think it's a great idea and something that I'll definitely take back to the team, to the concept of sort of a check mark. Do you understand this? We do not do follow-up to say, do you understand in which cases there have been only Europeans studied? Our service is also broad. We cover ancestry and other areas that are not as dependent upon ethnicity. So we feel like everybody has something to learn from our service. We do highlight the fact that genetic research is not comprehensive, and we want to be, again, part of learning more about that.
Okay. Briefly, so I could get one other question in. Okay.
But just a quick answer, we could improve our service to follow up. We also do not do that particular type of follow-up that you.
Okay. I was out for a while, so this question may have been asked in one way or another. And I'm going to ask everyone, starting with Dr. Becker. We've heard compelling testimony that the science is not there yet to meaningfully interpret the data that these kinds of genetic tests produce regarding risk for diseases. Not even good enough to be interpreted by health professionals. As a physician, I feel comfortable, though, that if I took a good history, did a good physical, and did some routine lab, I would get significant information on which I could predict, and useful information, a risk for certain diseases. Why then should someone order these tests, especially a racial and ethnic, somebody from a racial and ethnic minority background? Dr. Becker?
Well, certainly there are limitations in the state of science that are even higher in relative to other ethnic backgrounds outside of Caucasians. And we support the NIH's effort to ameliorate that problem. We think that being overlooked here is the motivational aspect of this particular service, and the fact that these conditions show some increased propensity for cardiovascular disease, clearly type 2 diabetes, things that are clearly actionable and affected by diet and exercise. So although we recognize the fact that these conditions are not predictive at this time, and that needs to be responsibly reported to the public so that they understand clearly. We spend a lot of time developing the extensive amount of information that's provided to the customer about that specific effort.
Dr. Rainier.
There are well-known limitations to the physical exam. There are well-known limitations to the tools that we use in everyday medicine. For instance, the National Cancer Institute just looked at the limitations of family history for screening for prostate cancer and breast cancer. And while indeed you've heard testimony today that the science may be early and evolving, you've also heard testimony today about the medical importance, for instance, of things like pharmacogenomic testing. And I think when you hear the totality of the testimony today, an important point to make is that none of us should be satisfied with the status quo. None of us should be satisfied with the state of the American healthcare system. And it's tests like these that open up a future of great use.
So I agree with what Dr. Vanier just said. In addition, we believe that people have the right to access their genetic information if they want to do that, and we think it's really important, and it's a great educational tool to learn about genetics within the prism of your own data. We think that's an important aspect to our service as well as getting people involved in the research that we're undertaking to advance our understanding of genetics overall.
Dr. Evans.
So as my testimony has indicated, I think that the value of the bulk of this information is extremely low. I think that if one can get less meaningful, it is less meaningful for those of minorities. I think that I also agree that people should have access to their own genomes. But again, I think that the claims made for that information should comport with reality. And I think that the idea of that this adds to motivation or adds to our information is clearly demonstrably incorrect at this point.
Thank you.
Thank you, Ms. Christensen. Let me thank this panel for their testimony, and thank you for appearing today to help us understand this problem. We all have a lot more work to do in this area, and appreciate you being here. So I'll excuse this panel, and I'm going to ask Mr. Kurtz to come back for a couple questions, if he would. Thank you. Mr. Coots, right?
Coots, yes, sir.
Coots, I'm sorry, Mr. Coots. Couple questions, if I may. Can we put up the slide of the predictions of the 48-year-old male, the one we had up earlier? First, question or two, and then Mr. Burgess had some questions on some other parts of your testimony on the vignettes, and we'll get to that. There's been some confusion. Identify the companies, company 1, 2, 3, 4, if you would, please, for us.
Company number 1 is 23andMe.
Okay,
2 is Decode, the one Dr. Burgess said I should look at, actually.
okay,
3 is Pathway, and 4 is Navigenics.
okay. Decode number 2, that was a company from Iceland, I believe we said, right?
That's correct.
Okay. That's all I had. You wanted to clarify some parts, Mr. Burgess, with this witness?
Yes, sir. We had two vignettes, one that dealt with the risk factors for breast cancer, and one that asked a question about obtaining a surprise for their fiancé. Is it?
Can we get those vignettes up?
What I was trying to
Without
do
the sound.
was okay. There you go. Can we identify the company so we're clear on that, because there was some confusion on the panel here, on the dais here.
Yes, sir. On the breast cancer, it is Navigenics.
Okay.
And the other one you wanted was?
Yeah, the awesome gift. Yeah, would be an awesome gift.
That's Pathway.
Pathway.
Yes, sir.
Okay, and again, we should just identify it for the record. It's the the individual wants to give his fiancée the DNA testing results, right?
That's right.
And that was Pathways. Okay. Do you have any further questions?
No.
No further questions. Thank you, and thank you for your clarification.
Thank you.
Okay, that concludes all questioning. I want to thank all of our witnesses for coming today and for their testimony. The committee rules provide for, and as we said during the hearing, members have 10 days to submit additional questions for the record. It's also been requested and unanimous consent that any of our witnesses who testified who wish to supplement their testimony will have 10 days to do so. That concludes our hearing. This meeting of the subcommittee is adjourned.